let's move to our next speaker, who is Genevieve Wojcik from the Department of Epidemiology at Johns Hopkins University.
Okay, so I wanted to first thank the organizers for having me today and also for the flexibility to talk to you remotely from Maryland. It's greatly appreciated. So my name is Jen Wojcik, and I'm an epidemiologist at Johns Hopkins University in public health, and my work focuses mainly on genetics and genetic epidemiology. And when we're talking about today is sort of how genetics is doing in terms of diversity. When I talk about diversity, I mean genetic ancestry, and what that means for the field. So I think I'm going to have, there's a lot to say in this talk in a short amount of time, but it's all based on this big premise, which is that we all know that a disproportionate level of chronic disease burden is found in minority populations in the United States. This is well documented. It's sort of, been well known for a long time. And yet the vast majority of our genetic studies to address these very health issues are overwhelmingly done in individuals of European descent and European ancestry. And so there's this big gap that's actually exacerbating disparities and making it worse and worse and worse. And so, there's a lot of reasons for why this is. And, when we try to address the bias that's currently found in genomic research, typically what we find is, you go down one layer, one step back, and you find the bias, and you realize, okay, but this is based on more bias and more bias. And it's really sort of turtles all the way down. And when I say turtles all the way down, I mean it's sort of this Eurocentric bias present. And what it really comes to is in biomedical research, what do we accept as the default? And the default for most biomedical research, not even just genetic research, is a white population. So this influences who we sample, how we measure the genetics even. So that's sort of the base part of the study design. It also affects the actual methods that we've developed to map genetics and the variants responsible for illness and different health outcomes. And then when we take those discoveries and we want to translate them, we go into biobanks, different clinical trials. Those are also not representative of populations that need the most help. And so you have this genomic health inequities being propped up by so many layers of bias that you really have to tackle each one of them, starting with the bottom, but really all at the same time in order to make any dent in what's happening. And so, I think that there's often a refrain of, well, why does diversity matter for genetics? There's a difference between race and ethnicity and genetic ancestry. So why would race or ethnicity or even genetic ancestry really matter? Especially when we know that all human beings are about 99.9% identical when it comes to their DNA. In the billions of base pairs of the human genome, we're all pretty much the same. We also find that there's more heterogeneity found within a population than between populations. And so again, why would it matter if we think the underlying biology is the same? And it matters because when you're looking at millions and millions and millions of variants, some of these analyses look up to 20 million genetic variants across the genome, these little differences start to add up. And these little differences contribute to what is essentially your fingerprint, your genetic fingerprint. And these little differences can differ based on where, historically the geography was in these different populations. This is really why we care about these aspects. And these differences have consequences. So I'll go a little bit deeper into these consequences a little bit later, but really for you to know that there are real consequences currently in genomic medicine. These include the direct measurement of genetic markers, such as BRCA1, BRCA2, medical genetics, where it's well documented that non-European ancestry groups have way more variants of unknown significance. So essentially, you'll do a panel, you'll come back, and we'll do all these markers, and I'll say, well, we found these things, but we don't know what they mean, which really isn't helpful. And so you have this lack of availability for this, biomedical progress for some populations. And then you also have this indirect measurement of genetic risk, whether it's GWAS, which I'll go into in a second, or apologetic risk scores, which is sort of the new, hot topic in genetics right now. And this is sort of this indirect measurement is reliant on so many markers that you have this poor transferability across populations. So the lack of diversity has actual consequences. These aren't hypothetical consequences in the future, but these are actual real inequities that are happening right now in medicine. And so I think, a lot of this talk is going to be focused around, race, ethnicity, and genetic ancestry. And I think it's really important to note that they're not the same thing. And they can mean overlapping sort of aspects of the data, but they're not the same thing. And the reason this is important is because they're often conflated in genetic research. And so it's sort of important for us moving forward to sort of set the stage when we think about it. In genetics, there is a conflict between the technical motivations in terms of why we, have had these homogeneous populations, that substructure, and that is based on genetic ancestry, versus societal context, which is race, ethnicity, or social constructs, but they have very real consequences for health. And so on this end, we're talking about race, ethnicity. And for genetic epidemiology, it's really interesting for us to look at this because you need both, and they sort of intersect. And you have to be very careful as to what you're looking at because they're very different things and they mean different things, both in terms of how you do your research as well as how you interpret your data, your research. And so that's sort of important for us to sort of set the stage moving forward. Okay, so how are we doing in terms of genetic research? What you can see here is a database that has been tracking the number of genome-wide association studies that have been published over the past 15, 16 years. Genome-wide association study, for those of you who are not familiar, is essentially you take a very large population and you do a lot of associations. So you check, is a single genetic variant associated with the outcome? And then you repeat that regression model millions and millions of times across the entire human genome to try to see where in the genome there might be genes related to that outcome. And it's a really, really powerful tool for us to better understand the biology. And so what I'm showing you here is from 2005 to 2020, the mean and median sample size for these published studies. Each one of the lines is colored by how this catalog has grouped the participants. I should note that it is a mixture of race, ethnicity, and ancestry for the way they've designated things. Some of it's geography, some of it's more US-centric sort of designations. And so that's sort of one thing to think about. But the main take-home message from this is that you can see that there's been this exponential increase in the sample size. These huge studies have been published on, especially recently with things like the UK Biobank and these really large Million Veterans program, all these very, very large studies. But they're almost entirely in European or European descent populations. That's that green bubbles. And this is both for the mean and the median. Now you can see for the other groups, they're lagging behind. They haven't followed the same trajectory. And even more on top of that, there hasn't been a lot of progress in the last few years. There's been some progress moving up and down, some deviations from the mean and median, but really there hasn't been as much progress. And so there is a saying that's often quoted where, a rising tide lifts all boats, but that is not true when it comes to who we decide to research. You see these very large sample sizes for European ancestry groups, and it's just not happening in the other groups. And what's really important for us to note is that these are published studies, which means they represent a very long-running investment in the research. It takes a lot of time and money and working person hours to get these done. And so this is decades of work reflected in who we publish on. So we really have to get started now in order to make anything better moving forward. And we can look at the numbers for this. I'm not going to focus too much on the actual numbers here, but just to say that for this GWAS catalog, which is curated and hosted both between NHGRI in the States and EBI over in the UK. About 78% of the individuals are European ancestry, European descent, 11% Asian. And then, when we think about US minority populations, it's only 1.3 and 2.4% for Hispanic, Latin American, and African American populations. Now, these portions and percentages here are not representative of the United States. They're not representative of global demographics for sure. And so you really see this disproportionate overrepresentation of white populations in genetic research. There's currently actually a diversity monitor that looks at this. So the GWAS diversity monitor, you can Google it and see it in real time. This was downloaded yesterday in terms of what's been published. And here they track things a little differently because every published study is a separate set of individuals to them, even though most published studies reuse the same large pool of individuals. But it makes it sort of more egregious, where you look and see almost 95% of the published studies have, the participants are European ancestry. Or 95% of the participants in published studies are European ancestry. And it's down to, if we combined African, African American, Afro-Caribbean, Hispanic, Latin American all together, there's still, less than 1% participants in published research. And so this, diversity monitor is actually a really great resource. And you can see if we just subset it to cardiovascular disease, which is, a huge burden in terms of mortality and morbidity in the United States and globally, you can see over time, there's been more studies published, but these huge, huge studies where there's, over 1 million participants are all European ancestry. And so you see again, this bias time and time again. And so it's really important for us to change this. There's several reasons, but one of the most pressing is that the gap is only going to get bigger. The shifting demographics of the United States as well as global populations means that if we don't act now, or we don't act yesterday, really, this gap is just going to get wider and wider and wider, which is not going to, help people who need the most help, and really why we do the research in the first place. And so I wanted to give you some real examples of what this actually means for people when it comes to their clinical care. So here is an example of what can happen when you don't, include diverse populations. This is the CYP2C19, a haplotype of it. A haplotype is just a combination of genetic variants that are usually inherited together. Now, this haplotype is found in 3 to 5% of European populations. They found that, if you have this haplotype, the drug clopidogrel, also known as Plavix, which is an antiplatelet medication, doesn't work as well for you. So that's really important for them to sort of know that. But they thought, okay, like 3 to 5% in European populations is not the end of the world. Like, it's okay. They can just change medications if it doesn't work. It's a small percentage. The problem is that they didn't look in other groups. And so if you actually look at other populations, there are some populations, specifically in Asia, where it's over 20% of the population has this haplotype. And therefore the drug doesn't work. And so this actually led to a lawsuit that I think is still ongoing, where the Hawaii Attorney General sued the maker of Plavix for false advertising because they have such a large Asian and Pacific Islander population in Hawaii. Therefore, the drugs were not performing as they were, advertised. And so this is a problem. And in the future, it'd be great if we could just directly genotype this haplotype, and you can see, yes, the drug is going to work, drug is not going to work. But what happens in practicality is that clinicians then rely on either self-identification in terms of the race or ethnicity, or an assumed race or ethnicity. And there's nothing really precise about this kind of medicine. And so it really is leaving people behind. Another example is in screenings. So this is a newborn screening for cystic fibrosis. They look at a specific panel for genetic variants. And this is a bit old, it's 2013, but still relatively, it's better, but not crazy better. And so what you see here is that, for different tests and different marketed tests to see for this newborn screening, there's a false negative rate. And so for these tests in white patients and white babies, there's a false negative rate in 3 to 10% of them have a false negative rate for these kids with cystic fibrosis. Now this rate increases in these non-white individuals. And so you have, in Hispanic populations, these Hispanic babies are coming out and they're being told you don't have fibrosis based on the genetic testing in 13 to 30% of the kids who were screened in this. For Black babies, it was 15 to 38%. And then in Asian babies, it was 23 to 40% of the time that if they were an actual case, they didn't get an informative result. They said it was negative. And so you have, again, this disparity in terms of who gets clinical care and who has access to these early diagnostics, which really make a difference in terms of treatments later on. Okay, so those are focused mainly on medical genetics. But the main point that I think the topic I want to talk about today is apologetic risk scores. You may or may not have heard of them. They're sort of the new kid on the block the last few years. There's a lot of hype around them, for better or for worse, in the genomic community. And so, let's go into what those are. So these are concepts. It's just important for us to know these concepts to sort of talk about the rest of the data issues. And they're a big thing both in academia and industry. There's a score being marketed through 23andMe where you can look at your entire genome and they tell you maybe, what is your risk for diabetes? I think they do type 2 diabetes is I think what they're looking at. And so that's available. There are numerous companies that will give you these polygenic risk scores. There are even some companies that will give polygenic risk scores for embryos. And so these are out there. The Pandora's box is opened. They're being marketed directly to customers. And so that's sort of already, they were at warp speed from the start to being out there. Really is incredible in a way. And there's also academic medical clinics that offer these risk scores. There's one at MGH where they do preventative genomics clinic for cardiac outcomes, where they'll use your polygenic risk score to better classify your risk and treatments. And so what's important for us to know is that the polygenic risk scores are often built upon GWAS. So if we look at the years 2000 to 2021, so that's almost over 20 years of genetics and published studies, you see that genome-wide association studies where you scan across the genome and try to find everything you can have been pretty big for at least over the past decade, where there's thousands of publications every year. But for polygenic risk scores, you see this is fairly new. There's this uptick in the last 5 years. And you can really see this if you sort of zoom in on the counts, where it's really sort of started to pick up speed, where now it's really in the zeitgeist and sort of a lot of polygenic risk scores being published. So what is a polygenic risk score, you might ask? I mean, this is not a genetic symposium, so I think it's important for us to know what these concepts are. But essentially what a polygenic risk score is, it says, we know that some genetic variants increase your risk for a certain outcome. Typically, we've looked at in medical genetics where you look to see how many copies of it do you have? Do you have 0 copies, 1 copy, 2 copies? And that's what they look at when they do medical testing or medical genetics testing. The polygenic risk score says, okay, like we know that there's some that have these big influences, like variants in BRCA1 and BRCA2. But if we look at everything across the genome and we sum up all these different variants, we can get more information of what your overall genetic risk is. And so basically you're summing up risk from numerous loci, from dozens to millions across the genome to create this continuous distribution of your genetic burden of a disease or outcome. And then what you do is you take the polygenic risk score, you take a population's polygenic risk score, and then you take an individual's risk score and you see, okay, where on this distribution are they? Are they high risk, low risk? And then hopefully that helps you better, tailor the treatment. And the idea basically being like cases and controls have different underlying distributions, but you don't really know that, so you're looking at an overall distribution to see people's risk. The polygenic risk scores can be used for several reasons. It can be used if we think about a person's lifetime, they're healthy, and then at some point there's the onset of an outcome. And so it can be used to determine disease risk, which is sort of the time till that outcome or onset. Once they do develop an outcome, it can be diagnosis with either of the disease or of a subtype. And then right now, there's actually a lot of trials looking up for disease prognosis, specifically pharmacogenetics, with how it can interact with treatment options. And these risk scores do often go beyond just genetics. You can add on things like biomarkers, BMI, also basic demographics like age, sex, race, ethnicity. And so they're really meant to complement existing clinical scores or sort of replace them if possible. And whether or not these are useful or not, I think is still a thing up for debate. But there has been shown to be some utility for them. What I'm showing you here is a study that was done in 2020, looking at the usefulness basically of a polygenic risk score for coronary artery disease. And they're comparing it to a well-validated clinical risk calculator, the pooled cohort equation, which is PCE. And what they show is that, PCE is pretty good at what it does. But if you add the polygenic risk score on top of it, you actually can improve the net, the net classification improvement is 4.4%. So if you use a specific threshold, you can better estimate people's risks. And so there might be some utility for these sort of tools in the clinic moving forward. And so I'm not going to go too much into what polygenic risk scores are doing right now, but I think it's important for us to sort of have a basis of what it is, because what's really the essential point of polygenic risk scores is that they are based mostly off of GWAS. So every single bias that we ever had in terms of a GWAS is now amplified because you're compounding it over millions of variants in a polygenic risk score. And so these biases in terms of representation still occur. And this can be, this is published in 2019, so it's 2 years old already, but it's not very much changed by now, where European ancestry studies are vastly overrepresented. They were, if you compared the proportion of participants in published PRS that are of European ancestry compared to the world population, they're about, overrepresented by 460%. It's a huge thing. And what was really jarring is that 67% of published studies only looked in European ancestry groups. They didn't even try to look in any other groups, which is really a shame. And then even more jarring is that, if you combined all the studies that had African or Latino, Hispanic or Indigenous peoples in it, and you combined all the studies, it's only 3.8%. So really not doing great on the representation thing. Mainly because it's built off of an already faulty framework, an already faulty evidence base, and so these biases have consequences for years and years and years and years, and it takes active efforts to change them from the ground up. And what does this mean for this? We've already shown before with medical genetics and direct testing there is disparities in this, and for polygenic risk scores it's the same. It might be even more drastic. What you have here is a paper by Alicia Martin in 2019, and what they did is they looked at scores that were performed that were developed in European ancestry groups, and then how they performed in other continental level groups. And what you see is that for East Asian individuals, the performance was about half of the European ancestry groups, and for African ancestry groups, it's down to almost 25%. So really badly performing models, and so this disparate performance of these polygenic risk scores can really exacerbate these health disparities moving forward. All right, so let's sort of set the stage that everything is very bad right now. Everything is not great, and I think that's really important for us to see. But one of the things that's really important also to note is that when we think about the different layers of bias, we can't address what we can't see. These studies that I'm showing you before, in which they tell you how we're doing in terms of representation, took a lot of work and effort on the parts of those investigators to bring all the data together, to do some additional analyses, get additional access to the data, because it wasn't actually very apparent from the actual publications. And so we know we need to do better. It's very clear. This has been very well known since maybe the beginning of this kind of research. But how much better and sort of what parts do we need to do better? That's hard to know. And again, you cannot improve what you cannot measure. You need to be able to measure things to see what needs to be improved. And this is really important for us on two fronts. One of them is I think it's important for us to spell it out and actually see what we accept as the default. This can be uncomfortable, I think, in some circles and some academic sort of circles as well, as to why do we accept these things as a default to begin with? I mean, I think that part of it obviously is the incentive structure in academia and research, and part of it is laziness, and that's an uncomfortable truth for all of us. The other thing is to spell it out. There's actually been a movement recently in the past year or so where some medical journals have added statements where you have to say, for a specific outcome, where does the actual burden of morbidity and mortality lie? What populations is it found in? And are those the populations that you're studying? With sort of this effort to push people to really think about how they're doing their research. The other reason is to join efforts and increase sample size and statistical power. To do that, you need to harmonize data sets. But you cannot harmonize data sets and really bring things together unless you know who they are and how that was dealt with. And so without this information, the data, all that money and all that effort to, to sample those people and recruit them and then analyze data just sits there unused. So it's really a shame. And again, the ultimate goal is, to both better inform the research moving forward, but also for the research that's already been done to have better interpretability, to have better sort of, to couch the conclusions in really more of a societal context without sort of, overstating the usefulness or understating. And so again, the first step to solving a problem is to measure the problem. And, we have a problem in terms of that. And this is because we don't have the data to measure it. We need to know the who, what, where, why, and how of polygenic risk scores. I'm focusing on polygenic risk scores because they're so new. There actually are standards around genome-wide association studies to some extent in terms of how they report things. And so because of this, reporting guidelines are a necessity to ensure standardization of how people present data, to ensure interoperability between data sets, and really help this move forward, since genetic data is very expensive to do research on. It's important to maximize the use of it. So about a decade ago, there was a reporting statement called the GRIP statement, and this was for genetic risk. It was structured like a manuscript with your title, abstract, intro, methods, results, and discussion, also known as an IMRAD format. And it had these basic fields where it says you need to tell us all these things. And so there was sort of a basis, but the problem was that this wasn't really adopted very well in the field. It wasn't well known. And then we think there were several reasons for this. Now, one of the biggest reasons is because the field has evolved. The field of genomic research has evolved, and it's changed drastically in the last 10 years. Now, these large-scale multi-center consortia are the norm. It's sort of standard to have to collaborate with international collaborations. And also, the motivation for a lot of genetic research is statistical power. You want the biggest sample size you possibly can have. And because of that, study designs are combined. And so it's a little difficult to have that information that's not really, the prior reporting framework wasn't well aligned with these priorities. There also, I think, is important to note that there has been a push towards transparency and reproducibility, as evidenced by this symposium today. Most notably about these fair data principles, which is that that the data should be findable, accessible, interoperable, and oh no, I'm forgetting the R all of a sudden, reproducible. So that's sort of important for us to note that there's this large movement, and this has resulted in the genetics community and a number of these large databases. The GWAS catalog, which catalogs all of the published GWAS. There's now a Apologetic score, PGS catalog, also GWAS atlas. There is some effort for this. And so, one of the first steps, again, that you want to do is see how the field's doing. And what I'm showing you here on the right-hand side is, for some preliminary fields that we decided to look at, how a paper is doing. Are they reporting them or not? And what we found is that a lot of papers either don't bother saying anything about this data, or they don't give you enough details. So they'll say, for instance, you see that almost 40% of papers gave insufficient detail for age. So they might have said, these are adult individuals, and that's all. They didn't tell you sort of what the actual age distribution was. And this is problematic because you can imagine that for an age-related outcome, you kind of need to know how old people are on the risk score and what it was trained on. And so because of this, we really wanted to sort of move the reporting guidelines and update them to what we have today. These reporting guidelines are published last spring when there was a multidisciplinary collaboration between folks that were statistical geneticists, clinicians, genetic counselors, ethicists, to really get at a comprehensive look of how we report polygenic risk scores and what information is most vital when we think about reproducibility, interoperability, and what is going to have most impact moving forward for this field. All right. And so what it looks like, it is largely, I would say it's largely similar topics as was in the original GRIP statement. but it's structured differently, and it's structured differently for a reason. And so for this, what we did is we took these risk scores. Now we have background, so sort of why you're doing this, study population and data, so who these people are and what your data, who your data is and how you did it. And then risk model development and application. So how did you make your model? What are the stats you use? What's your reasoning? And then how did you evaluate your model? This includes, the distribution of the model, discrimination, calibration, subgroup analyses. And then, we're very explicit about you need to have very explicit interpretation of it, as is sort of common in a lot of genetic or genomic studies. There is a tendency, I think, for folks to say, here is a shiny new hammer, look at all those nails. And that's how the papers sort of come out. And this is really a push to say, okay, like this is a very nice shiny new hammer. Apologetic risk scores are very, very neat. But why are you doing it in this population? Why are you doing it for this outcome? And what does it actually mean? You made this thing. What do you think it's useful for? And that includes the interpretation of it, as well as the limitations and how generalizable it is outside of things. And this, again, is a really big push for folks to have to spell it out, to have to say exactly what they're thinking, to not really cop out and say, we need further research. Okay, but you did this for a reason, so why did you do it? You need to say that. To really push back against those tendencies. And for one thing, first thing about too is that we had a very big push for the data transparency and availability. And this means that you have to share your results, the data, the individual weights. And there are different entities that do this in terms of PGS catalog, NHGRI, and then this. And so, this really big push for this data transparency and availability, that you have to share your data. This risk score does not do anybody any good if you hide it in your own server or your laptop. It needs to be shared with the world to sort of be benchmarked and built upon. And again, it was really important for us to make this sort of the pipeline of what you normally do in terms of the analysis, so that people are thinking about it from the get-go, that throughout the analysis and the pipeline they're looking through, they're both writing down what they're doing, but also thinking about, okay, I'm going to have to say this. That should inform what I do earlier on. And so that was sort of really important for us to think about. And again, this is a reporting framework. It is limited in its scope, this analytic validation and clinical validation. And it was important for us because we needed a strong foundation for eventual clinical translation. It was limited to a scope of a single publication, typically what that entails, because you're not going to solve everything in every paper. And so you need to have some sort of guidelines that are achievable in the single publication. Okay, so let's go back to genetic ancestry and diversity here. And I want to really pay attention to this because it's a really important part of this accountability when we think about reporting and pushing people to say exactly what happens. And this is because if we zoomed in into the previous plot, and just as ancestry, we saw that 60% of publications that we surveyed had insufficient details regarding genetic ancestry and or race ethnicity, and 30% of them didn't report it at all. There was no information about genetic ancestry or the race or ethnicity of individuals. And this is for a variety of reasons. Sometimes it was because they used geography, which is not necessarily informative, depending on where in the world they did the score. And that's sort of really important for us to note. There's also inconsistency in how they do it. So if they rely on self-reported race or ethnicity, there is a mixing of race, ethnicity, genetic ancestry, and all these. For example, one publication used the definition of African American to be over 50% African ancestry. But if you were European American, you had over 90% European ancestry. So if you had, 80% European ancestry and 20% African ancestry, you were just dropped from the analysis, which is a bit arbitrary in terms of, you're using racial terms for genetic ancestry and then making these sort of, cutoffs that make no sense. And most studies just restricted only to those of European ancestry. And so what I wanted to note with this really is that the reporting statements themselves didn't fix this. It rather showed the massive gap that's present and the basic misunderstanding around these concepts within genetics. And this is not a new phenomenon. We know that there's an ongoing discussion of what these all mean in terms of genetics. But I think it's important to know that this reporting framework, it's accountability, and you need to say what you did and who these people are, but it also reveals that we don't even have the language to do this. And that's something we really need to work on in genetics. And again, this is because the technical motivations for why we have these things, which is related to genetic ancestry, and the societal context and the health impacts is more about race ethnicity because of the effects of racism. They aren't the same thing and they clash. And so people sort of don't really know how to deal with that in their studies. And so, I do want to sort of talk briefly about why they don't match and why there's such a difficulty in the field right now to reconcile these things. I know I only have a few more minutes, so we're going to go through this pretty quickly, but, the history of human populations resulted in patterns of variation. This includes the frequency of variants, the correlation between the structure of the genome. What you're seeing here is people from Europe. They had to have all 4 parents from that country to be in the study. And what you see is that the genetic ancestry represents historical geography. We can use just their genetics, sort of project that in terms of how they relate to each other and recapitulate geography. What you see here is that these individuals, they recapitulate the geography of Europe based on how distantly related they are or closely related they are in terms of their genetics. So we do see these trends. And typically we can cluster on historical geography on a broader scale. So this really continental level look at things where people do cluster out based on where they are, globally in these different areas. Here you see a lot of different populations. This is the 1,000 Genomes Project, which is a reference panel. And what you see here is that, there are different areas in terms of your genetics that correspond to geography loosely. It doesn't look like the map because at this point, there's too much diversity to sort of break down nicely like that, but you see differentiation. Now this gets complicated when you have admixed groups. And admixed groups are those who have genetic ancestry from 2 or more continental level populations, so recent ancestry. United States, that's a lot of different populations. That's sort of African American, Hispanic, Latino groups. And so what you see here is each dot is a person. They have been colored by how they self-identify. And what you can see off the bat is that there is no way to cut this data up in a meaningfully discrete way. There is no way using genetics, especially with these admixed groups, to say, okay, if you're on this side of the line, you're one group. If you're on that side of the line, you're another group. It just doesn't, it's impossible. There's just too much diversity and it's continuous. And you have this sort of Africa, East Asia, the Americas being pulled out there, Europe, all because of history and colonialism and different things, So it's important for us to note this. And even if we push it out for another dimension, again, it's all continuous. These folks, race ethnicity is a very complicated concept, I think most of us know. And the way that it relates to genetic ancestry is very complicated. And unless you have this nuance and you're able to communicate this nuance, you really don't know who the individuals are in your studies. And so this really is a push for us to better know this. And this can be heterogeneity both between and within groups. The label of Hispanic Latino within genetic research is largely nonsense. It doesn't make a lot of sense because you have admixture from usually 3 different groups. It's usually indigenous to the Americas, Europe and Africa. And if I picked a single person out, this is each person's a vertical line that's colored by the proportion of their genome from that ancestry. If I picked a line out of this, I couldn't tell you where they identify, where they came from. No differences on average, but that doesn't mean that the individuals sort of clump together. And so it's very complicated and it's important for us to note that. And so, for this has been a lot of discussion in the genetics community and the biomedical research community around this, about how race is a construct. It's influenced by social, political, and economic factors. In epidemiological and clinical studies, we typically use self-identified race ethnicity, for better or for worse. But this can also be identified by the researcher, clinician, geography, and it can be loosely correlated with genetic ancestry, which is historical geography, but it's not the same thing. And it's really largely capturing different concepts. And so how do we do this now? And this really shows us the problem. Currently, when we catalog and we report things, it's all over the place. And so you're combining genetic ancestry, geography, nationality, race, all lumped into this one sort of blob and identifier. And so even when we think about European individuals, they lump people in this study as if they're European, if they're Caucasian, which is not an appropriate word to use, nationalities, such as Dutch, or they use genetic ancestry to cluster them with known populations. So again, we're moving it all together. And for the sake of time, I'm not going to go into this too much, but this is very messy because these concepts change, and the difference between self-reported ethnicity and the way that it's recorded in health systems, which now are the basis for a lot of studies, is inconsistent, where folks can be classified in the EHR, electronic health records, as different races or ethnicities at different visits based on self-identification, but mostly about clinician identification and who's really marking it off in the records. And so it's really complicated, both in terms of the data being messy as well as what it means. And I think it's also important to know that there's the way that even clinicians deal with this differs. Some clinicians think more about the race of the patient. Some of them think about the ancestry or geographic origins. There really is a lot of work to be done around this. And so just to wrap up here, because I have just a minute left, I think it's important that we have these reporting frameworks and reporting standards to push people to be accountable for what they're doing. But I think also what it lets us know is that when you try to actually write out what they need to report, you realize that we have a very shaky foundation for such a big concept in genetic research. And we need to do better for this. There are active conversations and publications in terms of professional societies, public conversations around this. And it really is embarrassing that it's taken us this long. And so we have a lot of urgency around this. And so, to sum this up, basically, it's important to understand the who, what, where, when, how, and why of genetic research. This is especially true of apologetic risk scores because you are compounding biases from numerous sources and across the genome, and then integrating it with clinical and environmental risk factors, which align more with race and racism. And so that's an issue. But we need to work on the foundation and the concepts to make sure that they actually are consistent. So even when people report, the words they use to report will mean the same thing. And just to finish this out, I think that it's also important for us to note who we're doing the research for. I showed you the demographics before from the QS catalog, how it's overwhelmingly European ancestry. And this doesn't represent the world population. It doesn't represent the US population, but embarrassingly, it represents who's federally funded, the faculty. And I know that we're not selfish people, but tend to work on people who are, like you, and there's sort of a bias. So this bias has to sort of be addressed in numerous fronts. And important for us to note for this. And so with that, I just want to say thank you for letting me come virtually and visit the symposium. And I'm happy to take any questions.
So we've got time just for, I think, one question, and we've got one in the chat from Alicia Moore. She says, thank you. This was a great and informative talk. Do you think there is fear in non-white participants in giving or entrusting sensitive data like genetics to repositories, researchers, systems that largely are trained in a white Western approach to medicine and science? Curious to hear your thoughts on potential other systemic reasons for a lack of data.
Yes, so yes, a fear is a big part of it. There are numerous studies looking at this, surveying both participants as well as communities to say their interest in doing genetic studies and why they would not. And there are several reasons for this. Some of it, yes, is fear. Genetic data is very sensitive. It gives you information not only about you as an individual, but about your family as well. And so it's sort of this, it has ramifications for the groups and your communities, not just the individual. And there has been abuse of this information. It has been abused, and sort of this trust has been broken, both in terms of the genetic research that I'm talking about here, but also in terms of, criminal justice systems and forensic genetics, looking at that. And there is reason, and there is, you can't blame people for being distrustful because the trust has been broken. And so when we think about increasing representation, there's no easy fix. And this because of that, it requires a long-term investment in communities. It requires that you listen to what the communities actually want in terms of the research. It's not just about increasing the numbers, but aligning your research with the actual priorities of those communities and making sure they have a stake. And so, I think that this would be really important for us moving forward. And people are doing this work, and there is some outreach on this method, on this front, but it's going to take time. And so, I think that's a reasonable thing. There's no reason to rush things that take time just by the nature of what they are. But yeah, there's definitely a lot of reasons why people don't trust scientists with their genetic data.
All right, we are at our break point. So let's thank Jen one more time. So for those in person and online, we will reconvene in a little over 25 minutes at 11:15 Central Time for our next presentation. Thank you.